I Heart You DNA. I'm Kate Wilson, a certified genetic counselor and host of All Access DNA. In case you missed it, we are now on YouTube. So if you prefer to watch video or are just curious to see if my face matches my voice, head over to All Access DNA on YouTube. And as my kids say, be sure to hit that like and subscribe. So for this episode, we are talking to Ana Morales, her about cardiovascular health and genetics. Heart disease is the leading cause of death in both the US and worldwide. Anna talks to us about genetic conditions related to our hearts and why over 95% of individuals with a genetic heart condition don't have testing. We learn about ways to change this and impact the almost 100,000 people in the US who die each year due to sudden cardiac death related to an inherited condition. Let's get started. Thank you so much for joining us on the podcast today, Anna.
It's a pleasure to see you, Kate, again and reconnect. It's been a while, and I'm really excited to talk with you more today.
Definitely. Yes. It's good to see you. I feel like we chatted for a while on a very regular basis and then hadn't seen you in a bit. So it's good to catch up.
Yeah, very.
And today we're going to talk some about cardio health because you're a cardiovascular genetic counselor. And I know you're currently working on your dissertation. So you have a full-time job and also getting a PhD. And you're looking at addressing the gaps in genetic testing specific to cardio conditions like cardiomyopathy, arrhythmias. And we've talked about this in a few previous episodes with some patients who have cardiomyopathy about the lack of awareness or the lack of genetic testing. Tell us more about why genetic testing is important for cardiovascular health.
Well, in general, and when I, talk about cardiovascular health, I think of cardiovascular genetic conditions, primarily conditions like cardiomyopathy, arrhythmia, familial hypercholesterolemia, congenital heart defects, aortopathies. Those are the top 5, and they're all inherited or heritable. There is clinical genetic testing available, and information from those genetic tests can change the care, the management of people who are affected with those conditions and their family members. So knowing our genetic risk through genetic testing and family history evaluation can be of tremendous advantage to people.
So it sounds like, there's knowledge out there. We have genetic testing. We have ways to detect these types of conditions, or at least know that somebody's at risk before something happens, or potentially find out this is what caused a condition that they have. And we talked to Greg Ruff was one of the guests we talked to from Dilated Cardiomyopathy Foundation about increasing the awareness. So not just access to genetic testing, but also just letting people know, like you mentioned, those conditions and that so many of them have this underlying genetic component. He told us a bit about dilated cardiomyopathy, but I don't know if you want to give us a refresher on cardiomyopathy, arrhythmia, some of the conditions that you mentioned and what they are, what they look like.
Absolutely. And before I get into that, I just want to make a quick point about Greg Ruff. He is fantastic. And in full disclosure, I am also a member of the DCM Foundation board.
Mm-hmm.
And Greg and I actually go way back. I was his genetic counselor. We met, and this is public information. I'm sure he wouldn't mind I share this here. So we met, clinically when he went to Ohio State. He has dilated cardiomyopathy. I explained his genetic testing results. I did the genetic counseling for his entire family. And I guess because I am a fortunate person, we managed to stay in touch even after I moved on and left Ohio State. And to the point that he recontacted me and invited me to join and run for a position with the DCM board, foundation boards.
That's amazing how it kind of all
Yeah.
came together. And we'll put a link in the show notes to the foundation as well, because it has some very helpful info there.
Great. All right. So you asked me about cardiomyopathies. So I'll start there and then I'll make the link with the arrhythmias. So
Okay.
the cardiomyopathies are, traditionally categorized by how they present clinically. Have dilated, hypertrophic, restrictive, rhythmogenic, left ventricular non-compaction, and they all present clinically in a different way. And then, some of them have an increased arrhythmia risk. And what we have learned over time is that in many instances, the increased arrhythmia risk in those cardiomyopathies is due to an underlying genetic arrhythmia risk. And then on top of that, we have the classically known arrhythmias like long QT syndrome, Brugada syndrome, etc., that also have their own genetic basis. And you may be wondering why the conflation of cardiomyopathy and arrhythmia. And what's happening is that there is a significant amount of overlap between these two. Let's take, for example, their SCN5A gene. This is a gene that when there is a disease causing mutation or variant present, it can lead to dilated cardiomyopathy. It can lead to Brugada syndrome, or it could lead to a combination of either cardiomyopathy or arrhythmia or a combination of both. So that indicates that it's often incredibly hard to pick them apart. Even at the genetic level. There's also studies showing that if you have a patient with a suspected genetic cardiomyopathy and you do broad cardiomyopathy arrhythmia genetic testing, in about 1 to 4% of those patients, you will have an arrhythmia gene. And the same is true if you do it in reverse. You suspect an arrhythmia, you will find a cardiomyopathy, a disease causing variant. And these are really good studies that were actually both led by genetic counselors, one in JAMA Cardiology, Lisa de la Fave Castillo, and the other
Mm-hmm.
one was Emily Smith, another cardiovascular genetic counselor in the Journal of Clinical Cardiology, I believe, if my memory serves me right. We also know that there are recent studies with atrial fibrillation, which is an incredibly common form of
Mm-hmm.
arrhythmia, that if you test individuals with early onset atrial fibrillation, less than 60, 40, 50 years old atrial fibrillation, you will find a cardiomyopathy, a disease causing variant. So the overlap and the blending and the progression from one to the other is just, incredibly complex. So the cardiovascular genetics community is coming to this growing consensus that these conditions cannot exist in silos. We have to integrate them. And we're shifting towards a broader paradigm for these, where like you still have to know the phenotype of this
Mm-hmm.
condition, right? To know what you're doing, know what you're looking for when, especially from the imaging and rhythm perspective, but from the genetic testing perspective, casting a wider net is crucial. So that's why when we say cardiomyopathy, we think arrhythmia. And when we say
Okay.
arrhythmia, we can, have also to consider thinking about cardiomyopathy.
Okay, got it. Because cardiomyopathy, I tend to think of it as like that's involving the actual like muscle of the heart. And then arrhythmia, I kind of think of it as it's like the function or like how the heart's beating, basically.
Yes. Yes.
But
That's
there's a lot
correct.
of overlap between the two. So that's why it makes sense. Even if you're maybe being evaluated for one, it might be a broader test that's ordered.
Exactly. A broader test. And when we take family history information, we ask about, a history of, abnormal heart structure, abnormal, like, for example, an enlarged heart or a thickened
Hmm.
heart wall. That's how we ask family history questions. But we also ask about, a history of cardiac arrest or Holter monitoring, which will give us an indication of how this risk factor is manifesting as a cardiomyopathy, as an arrhythmia, or as both.
Right, right. And then you mentioned a couple other conditions like FH or familial hypercholesterolemia. So I was wondering if you could tell us a little bit more about that.
Yeah. So FH, just like cardiomyopathy and arrhythmia, 1 in 250 individuals in the general population have FH. And FH is caused by a severely elevated cholesterol, LDL cholesterol in particular.
Hmm.
Runs in families, autosomal dominant, 50-50 chance if someone has it that their children will also be affected. And what happens is when your LDL is severely elevated, the risk of coronary artery disease, heart attacks, and stroke increases. So what we see in FH is striking family histories of early onset heart attacks, sudden cardiac death, and stroke.
Mm. Okay. And then you also had mentioned a couple of other conditions. One, involving like aorta. It's one that I think about when we hear about, particularly I would say in terms of like athletes or something that either have a heart attack or unfortunately like drop dead in the middle of an activity. Is this like aortic dissection? So I
Yes.
was wondering if you could tell us a bit more about what causes that or what that is.
Yeah, so that's another cardiovascular genetic condition. It's less common than FH or cardiomyopathy, but it is also underdiagnosed. So, from the epidemiology perspective, the true prevalence is unknown. But that said, what happens is the aorta, which is the blood vessels that carries blood out from the heart into the rest of the body, becomes enlarged, and it's usually a connective tissue or some other, tissue involved with the development of the aorta, that there is a genetic defect that leads to enlargement and eventually dissection. These conditions are also heritable. When someone is diagnosed with an aortopathy, that means an aortic aneurysm, medically speaking, or an aortic dissection, family members need to get their aorta checked as well via echocardiogram, but preferably a cardiac MRI. And genetic testing is very informative in the case of thoracic aortic aneurysms in particular, which involve, a wide array of genes, but also syndromic conditions with multiple system involvement, like Marfan syndrome or Loeys-Dietz syndrome, where knowing the precise gene involved can help the cardiac surgeon make decisions about when to intervene and repair an
Mm,
aorta that is too enlarged or about to rupture.
mhm, mhm.
Otherwise, without genetic information, the guideline is, I think it's 5 centimeters, and then you intervene. But when you have knowledge about the presence of one of these disease causing, thoracic aortic aneurysm or dissection variants, you can intervene at 4.5 or 4 centimeters enlargement. It makes a huge difference.
Well, and I guess that's part of having some of the information from the genetic testing then is it tells you what the guidelines are, what to look specifically out for
Yes.
in terms of doing an intervention or not.
Yes, and this is true for cardiomyopathy as well. Knowing
Mhm,
the genetic, etiology of a cardiomyopathy case can give the cardiologist indications for additional procedures, additional evaluations, medication management, lifestyle, even clinical trials. Same thing with FH.
mhm,
Knowing that someone has a proven genetic, form of elevated LDL cholesterol can guide, management and medication prescriptions, because they're usually more aggressive when it comes to genetic, proven FH versus non-genetically mediated LDL that's elevated. Congenital heart disease, congenital heart defects, same
mhm,
thing. These are present from birth, so less difficult to miss because babies are usually
mhm.
symptomatic. And although some cases are unfortunately missed, for the most part, they're caught when they're severe. Intervention by surgery is done right away. But genetic testing in those cases is also very informative. And the earlier, the better, because it can inform, the need for multi system management. Some of these heart defects are apparently isolated, but in fact, they are multi system syndromic conditions.
Mhm,
Some genes, like the NKX2.5 gene, can cause congenital heart defects and also arrhythmia. So, knowing the actual gene can also indicate increased risk for arrhythmia. So, I guess one summarizing point for cardiovascular genetic conditions is that, I don't know, 15, 20 years ago, this was kind of viewed as an academic research
mhm,
investigational activity. And that's no longer the case. Having a genetic evaluation, evaluating what someone's risk for any of these conditions, considering genetic testing is now a real clinical, very valid and useful tool that anyone, who is in the cardiology space should know about and use it, or refer to genetics professionals. But also the public needs to be aware of what these conditions are, and when to ask.
Well, and I was gonna say, like, when does somebody know it's something out of the ordinary or to see somebody like yourself to get evaluated? Because I do think, when I was in clinic taking family histories, heart disease is one of the most common things that comes up. I mean, we know it's one of the most common causes of mortality in the United States. So how do you know if it's something that needs additional evaluation?
That's a great question. And that's one of the things I would like to be emphasized from the conversation today, which
Mhm.
is, having early onset heart disease of any kind is not normal. And when I say early onset, less than age 60 is not normal. It's not something to ignore. Having severely elevated cholesterol, especially if it runs in families, it's not something to brush off. Having onset of heart disease during or soon after pregnancy, that's also something to pay attention to. The thoracic aortic aneurysm at any age is not normal. It's not something to ignore. Like, these are real red flags that should not
Mhm.
be ignored. And, I remember when I was in genetic counseling training a few years ago, the information that we had about cardiovascular genetics was minimal. I remember studying for the boards. It was like a bullet, a single slide with 5 bullets. And, for the most part, congenital heart defects, 1% of the US population can be genetic, outflow tract, left outflow tract disorders. And then the rest was multifactorial or environmental. That's it. And this is a genetic counselor training to get out in the field and do clinical work. So if you think of others who are not trained as specialists in genetics, one issue that has become evident to me recently is not only the lack of awareness, but the lack of, substantial education to be
Mhm.
able to identify patients who are at risk and to be able to select the right test, and then knowing what to do with the genetic testing information.
Mhm. Right. And I mean, it is a testament because it's something that, like you said, was research and kind of thinking about more academically, but it really is something that is clinical, should be done widely across the board today, should be something that is honestly even part of like a routine care is finding out some of these questions related to heart disease to then
Yes.
see if somebody needs to meet with like a genetic counselor. Why do you think that there is this to the awareness or to the access? No, I don't have the numbers in front of me, but it's a pretty significant amount of folks that could benefit from a genetic assessment and testing don't even get it, aren't even offered it.
Yeah, in the best case scenario, according to what we know from the literature, individuals who are at risk for TTR, this is cardiac amyloidosis. Those are the
Mhm.
ones that are, ranking the highest when it comes to genetic testing utilization at 6%.
Wow.
That's within the cardiomyopathy, and also considering arrhythmias and lipids. It's actually a serious concern when it comes to cardiomyopathy. Different studies, including the one I authored, 1%. The number, different databases, it stays around 1%. So it is incredible. And the answer, I know, is multifactorial. There is
Mhm.
no single cause. This is the research I am focusing on for my dissertation right now. I,
Mhm.
first of all, did a very thorough review of the literature. This was recently published, scoping review of implementation of genetic testing for heritable, cardiovascular genetic conditions
Mhm.
across the literature, very early stages of implementation for all the different cardiovascular genetic disorders, not just
Mhm.
cardiomyopathy. Then we also surveyed cardiologists from the American College of Cardiology. And in that study, the first author is Dr. Wilson Tang. We were able to gather really important insights about what could be going on with utilization across the board, not just
Mhm.
cardiomyopathy, but all other cardiovascular genetic conditions. What became increasingly clear was that cardiologists who participated in that study were concerned about the cost of genetic testing. They had limited confidence in identifying patients that needed genetic testing. And if they had genetic testing done, they had some limitations in understanding what to do next with those results. They also cited issues with accessing genetics professionals. They wanted to do it, but they wanted to do it in collaboration with a genetics professional, like a genetic counselor, and they either did not know how to connect with one or could not connect with one or simply would not do it unless they would refer or work with one. So,
Mhm.
so that's a really important signal that it's definitely not just awareness, because in this survey, there was a clear signal of some healthy degree of awareness. But what we also learned, and I am also seeing this from my own dissertation data, is that there is a fundamental education issue about particularly how to implement this efficiently in the clinic for the
Mhm.
betterment of patient care, right? Because one thing is to
Mhm.
say, I'll draw your blood and I'll send it to the lab and have no idea what happens next, as opposed to, this is my clinic. I will evaluate patients and I will have a plan to know what to do with each, usual case scenario, depending on
Mhm.
what the results are.
Mhm.
So that's just, at the individual level. Then we have system level and policy level issues that, we can go on and on, that have to do with insurance reimbursement, access to
Mhm.
genetic counselors, that are monumental pieces of work that need to be addressed. And, one thing I have also learned is that, implementation science is a team science, and this is not a one-man show. This is something that we should all kind of like sit around the table and say, what problem do you want? Because there are dozens. And
Mm.
each of those problems is a career if you want to do something in this space.
Yeah.
And, then connect the dots together.
Yeah, well, I mean, it still sounds like there's quite a bit of work to be done, but that there's also quite a lot of folks that would benefit from having this access. I mean, what do you think are like the top priorities, or what do you think are the top things that somebody, either a healthcare practitioner or somebody that's a potential patient, could do at this
Hmm.
point in time to try to either have genetic testing or to be able to better educate somebody about the genetics of cardiovascular health?
Sure. And that's a really good, thoughtful question. And I will address it. What can individuals do and
Mhm.
what field do, right? And
Hmm.
I think,
Mhm.
again, theme
Right.
of. So for individuals who feel like something is off, their cardiac history is, like I was saying, this doesn't feel normal. My family tree is, abundant with cardiac issues that I don't understand. First step, ask your primary care doctor or your cardiologist if you already have one. That's a great first step. But here's the problem, and I've seen this countless times. Patients who do that and then are dismissed
Mm.
without
Mhm.
even having their full risk evaluated.
Right.
And then their confidence is shattered. They don't talk about it anymore. That's tragic. Actually, potentially harmful to someone, medically speaking. So what I would also recommend to individuals who want to evaluate their risk is to, if that happens to them, or even if it doesn't happen to them, also go and find an advocacy group. And I have a few that I can share with you that you can link in the episode if you'd like, depending on the heart condition that may be of concern. Because the advocacy groups are actually starting to understand the magnitude of the problems. We've had advocacy groups for decades, right? And the reason
Mhm.
why this is because they always knew that patients needed help navigating the system. But with this new evidence, coming out that at best 6% of patients are getting tested,
Right.
they're also, waking up and taking actions in ways that are more assertive, more aggressive. For example, I know the DCM Foundation, for example, is supporting no cost genetic testing and
Mhm.
alternate pathways for people to getting genetic testing. The SADS Foundation, they have developed an incredible resource with talking points to help patients, combat those,
Mhm.
pushback that they may get when they bring up a concern to their cardiologist. And I think, that combined effort can really help push people forward through the system. Going to the National Society of Genetic Counselors website, nsgc.org,
Mhm.
find a genetic counselor. Genetic counselors want to hear from people who need help. So that's always welcome. And I am one. And if I cannot see you in clinic, I will connect you with someone who can. So we're all in this together. So that's as individuals. And then as a field, and this is an implementation science principle that I find both, pragmatic, but also it's one of the things I wish were different, that you have to analyze all your barriers by the strength of the barrier, like how bad is it, but also how feasible is it to address it. Like you ask about priorities, right? So for
Mhm.
example, access to genetic counselors, I believe, will solve so many of these problems right away. Because if, Medicare doesn't recognize genetic counselors as providers that can, independently bill for their services across the board, genetic
Mhm.
counselors will continue depending on unstable institutional funds or research funds and only see patients half a day, once a week, and then their wait periods are very long. And for cardiovascular genetics, it's only a few. So we can't say, let's work all together on access to genetic counselors, because then there are other things that we could be doing, like increasing awareness, increasing, opportunities for education, not just for cardiology clinicians, but even like genetic counselors who are not cardiovascular genetic counselors. What I am personally focusing on with my work is in the development of tools, tools that can help identify patients, scientifically validating what are the best questions for medical history, for family history that mean something, tools to guide individuals on like next steps after a genetic testing result, not just positive, negative VUS, but also if it's
Mhm.
positive and if it's in the lamin A gene, should you see a neurologist? Should you have
Right.
a Holter monitor? Things like that. And I am also working to, as part of my dissertation, work and co-design a new way to create smarter and more efficient systems. I
Mhm.
believe that what we have in place is fabulous, but it's not scalable. It extremely complicated. It involves way too many steps. And what I have heard from some patients is they don't like it. They don't like it that way. So I think it's something that will benefit our patients, our families, but also to our own benefits, especially, cardiologists and genetic counselors who would like to see more people and help more people.
Right, right. Well, and I think it solves one of the issues you brought up before, that part of the feedback pushback was I I would have a challenge like identifying these patients, or if I did identify them, I would have a challenge knowing like which test to order and then potential like what to do with them after. And so it sounds like that's one of the things that you want to tackle with the dissertation is how to implement some of these things,
Yes.
tools into the workflow to try to make that part easier, not so much of a barrier for the physician.
Absolutely. Yes. For the physician, for the patient, and for the
Mhm.
genetic counselors too. Because
Yep.
as part of my work, I have learned a lot from experienced cardiovascular genetic counselors who, would like to have more opportunities to work at the top of their scope.
Mhm.
And I have also talked with the cardiologists that work with them. And, unanimously, they tell me that they love working with genetic counselors and that they sometimes feel like their genetic counselors should be able to do more, and that there are so many repetitive tasks that they see their collaborating genetic counselor do that they wish could be delegated to someone
Mhm.
else or something else like a tool. And the
Mhm.
genetic counselors say, wouldn't it be great if I could, delegate some of these tasks and I can focus on, for example, post-test genetic counseling, variant interpretation, management,
Mhm.
family care.
Right.
So that's what I am trying to, and these are conversations that I had been exposed to as a cardiovascular genetic counselor anecdotally, but
Mhm.
now I'm generating evidence that should substantiate a more substantial change in how we
Right.
practice.
Right. No. I mean, I think that's excellent. And it's just, again, showing how there's research, there's putting, finding out this information, but then a real translation into, okay, now how do we enact it? So, like a direct correlation. So it's not this abstract, we just look at it and never come back to it again type of thing.
Yes,
Yeah.
exactly.
You mentioned some of the post-test counseling, and so going over those results with patients. What do folks need to do, like, if they have had, like, a positive genetic test or, they come in and they have a very strong chance of having one of these types of conditions? What kind of treatment follow-up is available?
Yeah. So again, it's different by condition. I will start with cardiomyopathy, which is like my niche specialty
Mhm.
area. So let's say someone has a cardiomyopathy, proven structural abnormality, they get genetic testing. It is now known what the gene basis is. And it turns out that the result is in what we know as an arrhythmogenic gene. And let's use, for example, the lamin A gene increases someone's risk for arrhythmia. So for that individual, I can say we found the cause of your cardiomyopathy. Now we have a name and a mechanism for it. Your family members can get tested for the mutation that we identify in you, and tell
Mhm.
if they are at risk or not. And we have plans for each scenario, positive or negative, in your family members. But for you, we have a better care management plan. And this means that we need to make sure that we monitor you closely for arrhythmias, because you can have an onset of a potentially lethal arrhythmic event that could be prevented. How? If we do more extensive arrhythmia monitoring. So I will refer you to an electrophysiologist if you haven't seen one. I will talk with your electrophysiologist if you already have one, to let them know about this gene change. They need to now follow you more closely. And one of the most powerful insights that we gain from findings such as the one I described, dilated cardiomyopathy and a lamin finding, is that usually an implantable cardiac defibrillator, which is what
Mhm.
fired when someone has a lethal arrhythmia to reset the heart rhythm to normal sinus rhythm. Usually, if you have dilated cardiomyopathy, your ejection fraction, which is one of the measurements to evaluate heart health, in that case,
Mhm.
the heart's ability to pump blood out. So when you say 30%, only 30% of what's supposed to be going out is going out, and that's not good. That's an indication for a defibrillator, because the muscle is weak enough that, because of, you can imagine it being weak, wobbly, large, that can predispose, structurally to an arrhythmia as well, especially if you have a lamin mutation that pathophysiologically increases the risk of an arrhythmia. We need to put a defibrillator, right, at 30%.
Mhm.
But let's assume we didn't know about lamin A, you use the 30% mark. If you knew about the lamin A risk factor, you would not wait until the ejection fraction is that low. You would start thinking about it at 45%, at 40%
Mhm.
ejection fraction. So your threshold is, different. When you know that someone is at risk for arrhythmia in the setting of cardiomyopathy, for the decision making about a defibrillator. And unfortunately, what's happening in practice, and I have, an ongoing study, part of it was presented at the Heart Failure Society of America recently, last month in September,
Mhm.
that a lot of these cases with arrhythmogenic gene findings are identified after they put the defibrillator in, after
Hmm.
someone has a cardiac arrest and
Right.
survive, and someone says, this is too serious. Maybe it could be genetic. And what we are trying to do is educate and raise awareness so that these decisions about genetic testing are made before some, you
Right.
know, very tragic event like that occurs, so that your defibrillator can be placed at a time where your cardiac health is not so bad, and you can avoid, that level of morbidity or, God forbid, mortality.
Right. Right. And I mean, I think that's what can be scary with some of these cardiovascular conditions is sometimes you don't have like a warning sign, right? It is something that's fatal, unfortunately. And so I think another reason why I'm so surprised about the fact that there is genetic testing, there is a way to identify some of these folks before that happens, and that there's still that kind of gap in care in terms
Yeah.
of finding those folks.
Yes, and we're doing what we can to change
Yeah.
that, right? But it
Yeah.
wasn't until recently that I personally, as a genetic counselor I have been in this space since 2007.
Mhm.
Years is that? Almost 20 years, right? And I personally was not aware that the
Mhm.
problem was so profound, because
Yeah.
I was in an academic center surrounded by experts, and the patients kept coming in, and it was a completely skewed perspective
Mm.
that our clinics are full, things must be fine. But we were
Right.
not looking at the problem from a more system level or community level
Mhm.
perspective, where, like, there's still so much work to do. So many
Right.
people at
Right.
risk out there.
Right. And I was gonna ask too, because I think with some of these cardiac things, they can affect like kids and teens. I mean, do you recommend genetic testing on folks younger than 18, or how do you handle those conversations?
Great question. We usually get that one a lot. And thankfully, the American Heart Association has a statement published in 2021 outlining consensus. So if a minor, regardless of age, right,
Mhm.
if less than 18, has a cardiovascular genetic condition, the findings of one of these conditions, genetic testing is recommended, especially if there is evidence that the genetic test will help manage their condition. And as I said, there is
Mm-hmm.
rarely an exception for the rule that genetic testing can change management. And so that's not controversial. What has been controversial is the case of, say, I have aortopathy. Let's say I
Mm-hmm.
have a cardiomyopathy again. I have it. I get tested. I'm positive. I have a 5-year-old. 5-year-old is healthy, doesn't have any findings of heart disease. We've done echoes, we've done EKGs, child looks fine. Should we do a genetic testing in that child? That's when it becomes tricky because usually cardiomyopathy manifests later in life, right? So
Mm-hmm.
people like young adults, especially if there's a genetic predisposition. And so the concern is what will happen between age 5 and age 40, 50, when, that's the window for onset of
Mm-hmm.
cardiomyopathy, with the livelihood, the decisions of that child. If we know that they're positive, are we going to worry too much about them? Are we going to create unnecessary anxiety? And
Mm-hmm.
so what the consensus is that unless we have absolute evidence that the condition only manifests in adulthood, there's probably no indication for testing that child because, of those concerns. But if I take a family history and I have evidence that in that particular family, cardiomyopathy can also be early onset and has been a problem in children in that particular family, that warrants genetic testing in that child. It would be imprudent not to.
Mm-hmm.
There is
Mm-hmm.
also a rationale for supporting genetic testing in the case of, parents, families that just simply want to be proactive because,
Right.
it's our child, it's our information, we deserve to have it. So it is in this space that things can get a little bit grayish. And that's why it's recommended that it's a shared decision making process, ideally with a genetic counselor in the team that can, really patiently, sit down with families and make sure that an informed
Mm-hmm.
choice has been made.
Mm-hmm.
And in every case, because they're minors, parental consent and child assent.
Right. Right. Well, and I think that's even more important to then kind of advocate to getting to see somebody like yourself or somebody who specializes in this area because you're familiar with how to then work with somebody who's under the age of 18
Yes.
and what needs to be in place. Another question that I was thinking about too as we were talking about it, because we're talking about like kind of the treatment and some of the ways to reduce risk or try to prevent something from happening. How does things like lifestyle, diet factor into this? Because, it's sort of, I think a lot of times with heart disease, you hear healthy eating habits, exercise. But if it's something like an underlying genetic condition, I mean, does diet, exercise still help? Does it not matter? How does that play into it?
So I guess the answer really depends on the condition, like FH, familial hypercholesterolemia, for example. It's
Hmm.
genetic, it causes elevated LDL cholesterol. And for people who are diagnosed with FH, they have recommendations for a specific diet that it's low in triglycerides and,
Hmm.
cholesterol. They also have recommendations to staying active through exercising, etc. But we also know that those, recommendations that are really for everybody and even more so important for people in FH are not sufficient. They need medication.
Okay.
So lifestyle changes in a condition like FH are supportive but not curative.
Gotcha.
Now,
Okay.
when it comes to cardiomyopathy, it gets trickier because in cardiomyopathy, the problem is that some of these conditions, as I explained before, have also an underlying arrhythmia risk. And the concern is that, putting someone at risk for a little arrhythmia, sudden cardiac arrest because of their exercise activity. And for that reason, there are specific guidelines and recommendations that use genetic information, use the patient's clinical, specific clinical presentation of, what cardiomyopathy is present to prescribe an exercise program that is really beneficial. It used to be in the past that you were diagnosed with one of these, genetic cardiomyopathies, and even if it wasn't genetically proven, people would think default no exercise. And people
Hmm.
really suffered. That's not good for overall cardiovascular health. That's not good
Mhm.
for someone's quality of life. So we have learned so much that, again, it's based on the clinical presentation, on the genetic information we have on the patient's preferences. And just like I discussed with testing of minors, another personalized shared decision making process.
Mhm, mhm. Well, and that's helpful to know, like, that there is some influence that you can have by controlling, like, lifestyle factors, but there's still things that you're going to need treatment or medication for, like you said,
Yes,
in that space. So again, another reason to potentially find out what's going on or if you have one of these things.
exactly.
I know we've been chatting for a bit, and I appreciate your time. Before we wrap up, are there other things that you would want folks to remember about genetics and cardiovascular heart health? Is there anything we haven't gotten to that you think it's really important for them to know, or just one thing you want them to remember?
So, yeah, thank you for the opportunity. What I would like to add is related to what we were just, discussing about, lifestyle and risk factors that are not genetic.
Hmm.
We have also learned recently about the role that environmental, non genetic factors can play into someone's genetic background. And I want to make it clear that there are environmental causes that can lead to heart disease by themselves. Smoking,
Hmm.
tobacco is a great example. Well established risk factor for coronary artery disease. Infections such as
Hmm.
Chagas disease, parasitic infection that can cause cardiomyopathy and heart failure. Those can lead to cardiomyopathy on their own and are not genetic. But what we have recently, and when I say recently, last 5 years or so, is also identified in the cardiomyopathy space. You may have probably heard of people who develop heart failure or cardiomyopathy because they abused alcohol. And there's even an ICD code for alcoholic cardiomyopathy. People who develop heart failure and cardiomyopathy because they had chemotherapy exposure to the chest. Usually people with breast cancer who also get cardiomyopathy. People with pregnancy onset
Hmm.
cardiomyopathy that their cardiomyopathy was attributed to your body just could not keep up with normal pregnancy demands. And what we have learned is that so many of these cases are underlined by cardiomyopathy disease causing variants, in particular, variants in the TTN gene,
Hmm.
which globally is responsible for 20% of cardiomyopathy. And
Okay.
I mean, I'm telling you, and I get goosebumps. I'm thinking about a particular person that I met that has cardiomyopathy caused by a disease causing variant in the TTN gene, runs in the family. His dad died from cardiomyopathy very early on. He liked to have his drinks and party, but he was shamed for like throughout his life for being a drunk by his cardiologist. And, the family history was ignored. The age at which he developed this out of
Mm,
proportion alcoholic cardiomyopathy was not really thought about carefully.
right.
And now the family is, realizing in hindsight, this was tightened. This was not, my dad being a drunk. And I'm
Right.
sure that's not the only case. There's a lot of people out there who need to understand that when it comes to cardiovascular health, it's a spectrum. And this is why it has to be a team effort with genetic specialists and cardiology specialists to really provide the most well rounded care.
No, I mean, I think that's hugely important is you don't want anybody to take a sense of your lifestyle is we're just automatically going to assume that's the cause and dismiss anything else, right? Because then that also allows you or keeps your healthcare providers from looking things at all different angles to see if there's anything else. And there could be a combination of factors. So to just kind of write it off as just this one thing without looking further is really dismissive and not great healthcare because, like you said, they missed something completely.
Exactly. And that's like, I guess, the last point I would like to make. And it's an emphasis. I already made this point earlier in our conversation. If you are someone who thinks that something is off, that you think that, heart disease runs in your family, talk to your doctor. If you get pushback, go online, find an advocacy group, reach out to a genetic counselor. Don't give up. You're probably onto something very important.
Thank you. And I think that's a great point to leave on. And we'll also include those additional resources you mentioned in the show notes. So if somebody is looking to try to get more information or to find a genetic counselor, they can go there as well.
My pleasure. Thank you for having me. It's been great, joining this podcast with you and being able to, you know, tell you and others who are listening about this important topic.
For more information about this episode, visit allaccessdna.podbean.com, where you can also stream all the episodes of the show. Any inquiries on the podcast can be sent to allaccessdna@gmail.com. Please rate and review the podcast on Apple, Spotify, YouTube, or wherever you listen. This helps other people like you discover the show. Note that this podcast is for entertainment and education and is not intended to be a substitute for professional medical advice. Please consult your physician with any questions you may have regarding your health. All Access DNA is an independent podcast hosted and produced by me, Kate Wilson. Designs by NKJ created the logo. Thanks for listening and join us next time.